Bismillahirrahmanirrahim. Welcome to the channel. Today we will talk about benign condition affecting the inner ear, and let's start. This is abbreviated as BPPV, and it stands for benign paroxysmal positional vertigo. So as the name indicates that this is a benign condition, it is intermittent. It occurs with a certain position of the head and it causes the vertigo. So before proceeding, please subscribe the channel so that you are not going to miss any succeeding videos. So it is a benign condition. It means it will be a self-limited condition which is characterized by episodic vertigo and nystagmus of brief duration, and it is provoked by assuming a very specific head position. So whenever the head will go in that particular position, which is a offending position, patient will feel vertigo and there will be nystagmus on examination. And as the position of the head is neutralized or corrected, this vertigo will disappear, and of course the nystagmus as well. Usually the posterior semicircular canal is the culprit, and this is a disorder of posterior semicircular canal, but other canals may also be involved, so that's why we can say that there can be sub classification of this BPPV, that mostly the posterior semicircular canal, otherwise lateral semicircular or anterior semicircular canal can also be the responsible for this disease, or this disease may be involving the bilateral semicircular canals. It is one of the most commonly recognized vestibular disorder in the patients attending the vertigo clinics. Uh, Age range is very vast, from 11 years to 84 years in one study were noticed, and 54 years was the mean age. 107 cases per 100,000 population per year are being reported. The prevailing theory of BPPV, that is benign paroxysmal positional vertigo, is that autoconia, which are none other than calcium particles, are shed from the neuroepithelium of the utricle, which we call as utricular macula, and they migrate to the posterior semicircular canal. In the posterior semicircular canal, these autoconia particles, they settle into the sensory organ of the posterior semicircular canal, which we call as copula, and it will be called as copulolithiasis. Some of the autoconia particles, they continue to float freely within the endolymph of the posterior semicircular canal, and there we call them as canal lithiasis. So this is the diagram of the inner ear. You know that the labyrinth, it consists of your utricle and saccule. Then this is the utricle and the saccule, and these are the three semicircular canals, and this is the endolymphatic sac. Dilated end of these semicircular canals, they are called as ampulla of the respective canal. And this is the autoconia, which is freely floating within the endolymph of the posterior semicircular canal. That's what we call as canal lithiasis. And if it settles down on the neuroepithelium of these canals, which we call as copula, then we call it as copulolithiasis. And this is actually, you can see, these are visible there as a stone, calcium particles. So due to the degeneration of the neuroepithelium of the utricle, which we call as macula, there is a release of autoconial debris, and these crystals of the calcium carbonate, these float freely in the endolymph, and whenever head attains a critical position, there will be settling of these autoconia on the copula of the posterior semicircular canal, which is the sensory epithelium of the semicircular canals, and there will be displacement of the copula leading to the vertigo. So this is the utricle, this is the posterior semicircular canal. When head rotates, the endolymph, it is moving in the opposite direction from the movement of the head, and this copula, it will be moving towards the position of the head. And when head rotates in the opposite direction, endolymph is in the opposite direction and the copula is in the same direction of the head position. And due to the movement of the head, the hair cells in the copula, they are being stimulated and their firing starts, and there will be increased neural firing, which sends the stimulus to the brain about the position of the head and the body. So this is termed as a benign because it is self-limiting, naturally resolving disease. It is observed that on an average within 2 weeks it settles down. Maximum time was observed more than a month, but still it is a benign condition. It is self-resolving, but we cannot label it as fully benign, especially in old age patients, because in old age patients, if this condition occurs and due to this condition, the patient, for example, falls down, so there may be uh, accidental injuries like head injury can be there. There can be fractures of the bones as well. So this benign condition can cause a lot of morbidity and mortality. Overthinking is always traumatic. So there are certain predisposing factors like inactivity, no exercises, acute alcoholism, those who are drinkers, any major surgery leading to bedridden in convalescent period, any central nervous system diseases. Still, it can be idiopathic in a majority of cases. Any ear disease like otitis media, vestibular neuronitis, Meniere's disease, autosclerosis, sudden sensory neural hearing loss, trauma, acoustic neuroma, or cervical vertigo. In the differential diagnosis, we have to consider those diseases which can cause vertigo, like Meniere's disease, in which there is episodic vertigo, but that is associated with fluctuating type of sensory neural hearing loss and tinnitus, inner ear concussion, alcohol intoxication, labyrinthitis, vascular loop syndrome, posterior fossa lesions like acoustic neuroma or meningioma, central origin diseases like cerebrovascular accidents, that's what we call as stroke, multiple sclerosis, cerebellar degeneration, then vertebral artery insufficiency, or cervical vertigo. There are certain risk factors in a younger age group, say from 18 years to 40 years. The risk factors are if a person is involved in yoga, because in yoga you have to adopt certain postures, so sudden change in position of head can be critical, leading to the displacement of autoconia from the utricle and landing into the posterior semicircular canal, leading to the benign paroxysmal positional vertigo. Then running on pavement or on treadmill, then those professionals who are involved in ceiling painters, Painting, like, because then they have to extend their neck. Those mechanics, especially who are working under the objects like car mechanics, then aerobic exercises, jogging, and of course the swimmers, that they are also more prone to. So all these are the risk factors in younger age group. Those who are elder patients, that is more than 40 years, in those the head trauma or ear disorders like vestibular neuritis or labyrinthitis are the risk factors. Then certain positions, they are more likely to provoke vertigo, like lying back in the bed, arising quickly, looking up, and reclining for dental or hair treatment on that specific chair. So patient will feel vertigo, lightheadedness, imbalance, nausea may be there, and this is intermittent pattern, that is episodic. Diagnosis really is clinical, that is on history. Physical examination is to rule out all other diseases in the differential diagnosis, and we can do a test, clinical test, which we call as Dix Hallpike test. What is this test? That patient is sitting on the couch like this, and you ask the patient or help the patient to turn the head at a 45-degree angle, and then patient is asked to lie flat in supine position on the examination couch and head still turned 45 degree and is brought 30 degree below the edge of the couch, and you will ask the patient about vertigo and you will observe for the nystagmus. Hearing tests, of course, will be normal in these patients. Caloric test and electronystagmography may be normal during the episodes, but this Hallpike test will be positive. That nystagmus will be there when the affected ear is undermost. But there will be fatigability, that if the patient assumes same position or you repeatedly do this Hallpike test, then there will be fatigability. We can go for posturography as well. Now the nystagmus which will be observed. By the way, uh, this vestibular disorders are the diseases which are affecting the vestibular apparatus. The symptom is vertigo and the sign is nystagmus. Nystagmus, which we define as involuntary oscillatory movements of the eyeball. And this disorder may be due to central causes in the brain, or these may be due to peripheral causes, that is in the vestibular apparatus, as the disease we are talking about is involving the utricle and posterior semicircular canal. So this is a peripheral disorder, because for maintenance of the balance it is a reflex arc, and any reflex arc needs an efferent limb, which is vestibular apparatus and vestibulocochlear nerve in this case, then central connections, and then there is an efferent limb. So just by looking at the nystagmus in the clinic, we can differentiate whether it is due to a peripheral cause or it is due to a central cause. So this is very important to understand. From your physiology knowledge, you know that a nerve current is being passed as an action potential. And what is an action potential? That we give a stimulus to the nerve, then there will be a latent period, and after that there will be depolarization and repolarization, and that is the production of action potential, and this is how the nerve impulse is being generated and the information is being carried out. So in a peripheral nystagmus there will be a latent period of 5 to 20 seconds. This peripheral nystagmus, it will be in a horizontal plane, that there will be a slow component towards the affected ear, and then there will be a fast component, that the eyeball will come to the neutral position or central position by the orders of the brain, which will try to settle it down. So there will be a slow component and there will be a fast component in the horizontal plane. Then if we repeat this, there will be fatigability. So fatigability is a characteristics of peripheral nystagmus. Peripheral nystagmus will be associated with vegetative signs like perspiration, sweating, palpitation, nausea, or even vomiting. In contrast, the central nystagmus, there will be no latent period in case of central nystagmus. Central nystagmus can be in any direction. Just like peripheral nystagmus, which is only in the horizontal plane, central nystagmus can be in any direction, whether it is in the vertical plane or it is in the horizontal plane. In peripheral nystagmus, I just mentioned there is a slow component and then there is a fast component in the horizontal plane. While in central nystagmus, the movement of the eyeball will be seesaw movements in any direction, just like a seesaw movements, irregular movements. There will be no fatigability in case of central nystagmus. Whenever you will repeat it, central nystagmus will be there. While peripheral nystagmus, it gets fatigued after repetition. Central nystagmus is not associated with vegetative signs like sweating, like palpitation, like nausea or vomiting. So movement of the otolith, it leads to the flow of endolymph, and then the direction of the cupula in the posterior semicircular canal changes, which leads to the excitation of the vestibular nerve, and there will be stimulation of maculospinal reflex, and the symptom comes which we know as vertigo. And this excitation of the vestibular nerve, it leads to maculo-ocular reflex, and it leads to the appearance of a sign which is nystagmus. So management is mainly conservative, and we can do some physical maneuvers. Patient can be advised to go for some exercises. Very, very rarely in stubborn cases of BPPV, we have to think about some surgical procedures. So reassurance, and in acute attack, we can go for labyrinthine sedatives. Then as in the pathophysiology we saw, basically this is the autoconia which are being displaced from the utricle and they lodge into the posterior semicircular canal. If by certain maneuvers we are able to bring back these dislodged autoconia from the posterior semicircular canal to the utricle, everything can be settled down. And for that, we can do what we call as Apley's maneuver. What is this Apley's maneuver? Diagrammatically, I just try to explain it. That you ask the patient simply to sit in the bed, examination couch like this. Then you ask the patient to lie flat on supine position and his or her head is turned 45-degree angle towards the affected ear. And then you wait till vertigo is there and nystagmus is elicited. Then you just wait in this position till vertigo disappears and nystagmus also vanishes away. Then you turn the head towards the opposite side at 45-degree angle. Once the head of the patient is turned towards the opposite ear at 45-degree angle, then you ask the patient to move his whole body in a semi-recumbent position like this, as you can see in this figure D, and just wait for some seconds there. Then you ask the patient to sit up with the legs hanging at the edge of the bed, and head or the neck is bent 20-degree downwards, so that his or her chin is pointing towards the chest. So this is what it is, Apley's maneuver. What happens in this Apley's maneuver actually? So this is the position which I just described, that make the patient to lie down in head hanging position with head turned 45-degree. Wait till the vertigo and nystagmus subsides, because this is the critical position in which we expect this vertigo. After that, the head is turned towards the other side, and then rotate the whole body and head away from the affected ear to a recumbent position, and then patient is brought back to the sitting position with the head still turned to the unaffected side, and then head turned forward and chin brought down to 20 degrees. And you have to instruct the patient to maintain upright posture for next 48 hours after this maneuver. So what happens, that this is a repositioning maneuver, will give you an idea that in this figure A, this is copula, and the particles are there in the semicircular canal. So when head is turned towards the affected ear, these particles, they flow in the endolymph of the posterior semicircular canal, and when head is turned in the opposite direction, these particles, they continue to flow, and when the head is turned down, these particles which are displaced from posterior semicircular canal, they come back to lie into the utricle. This is another maneuver. This is a bit simplified maneuver as compared to Apley's maneuver. Here just simply ask the patient to sit like this with the legs hanging down on the edge, and then ask the patient looking towards the opposite side, and in the same position patient lies in the bed with the neck still looking towards the opposite side or upper side, and then suddenly the patient comes to lie in the opposite direction. So again, the purpose is the same, that the autoconia, they are displaced from the posterior semicircular canal and brought back to the utricle. So patient should be advised to wait for 10 minutes after the maneuver is performed. Don't let the patient to drive later on. Sleep in semi-recumbent position for next 2 nights, and for at least 1 week should avoid the provoking head positions. So these are the post-maneuver instructions. Then there is another maneuver which is we call as Brandt-Darref exercise steps. That in position 1, the patient is sitting like this. In position 2, patient is lying, just like in Simon's maneuver. Then again the neutral position is attained, and then in the opposite direction, the patient is lying like this with the head turned toward the upper side. Then, as I told you, not only this all was about posterior cupolithiasis or canal lithiasis, which is really affected, but other canals can also be involved, like lateral canal or anterior canal, or there can be multi-canal patterns. And this is the diagram which is telling us different maneuvers according to the semicircular canal which is involved. In posterior canalolithiasis or copulolithiasis, we can go for Apley's maneuver or Simon's laboratory maneuver or Brandt-Darref's exercise. In horizontal, these are the maneuvers available. In anterior canal, reverse Simont or Krivitz maneuvers are available. So all these theoretically you should have an idea, but usually the posterior semicircular canal is involved, so we must have an idea of Apley's maneuver or Simont's maneuver at least. So in those very few cases in which this disease is very stubborn, then we can think about some surgical intervention, and of course the options which are available to cut the nerves supplying these canals, because these are the nerves which take the information from here as a afferent limb of the arc. So singular neurectomy is the option. Vestibular nerve section we can go for, or posterior canal plugging can be done so that there is no neural firing from the posterior semicervical canal. And lastly, we can think about labyrinthectomy. And as you can see, labyrinthectomy is a destructive procedure, and for a benign condition, of course, we would not opt for, but theoretically, to complete the list, we have to add it. And here I leave a question for you as well, that what is singular nerve? So with that, we come to the end of this discussion. So if you think it is beneficial for you, please subscribe the channel so that you are not going to miss any more informative videos, and share it with your friends. Thank you very much for watching.